Hey guys, welcome to our lesson on hematology. For this lesson, we'll be focusing primarily on the general assessment and management of hematological emergencies. Let's go ahead and get started. Topics for this will include anatomy, physiology, pathophysiology review, assessment and management, and then managing specific patient problems. When we think about hematology, we think about blood, right? Hemo meaning blood, ology meaning the study of. In this case, we're talking about the study of blood and blood-forming organs. This includes a multitude of disorders from red blood cell issues, white blood cell, platelets, and coagulation problems as well. We do know that some hematological diseases are genetic in origin as well, so they can get passed on from family members throughout the different generations. Let's take a quick overview for our anatomy and physiology, along with some pathophysiology. Most of your lesson will actually be on Khan Academy, but we'll do a quick overview. We know that there's some different components of the blood, or components of the hematological system, including the blood, the bone marrow, the kidneys, the spleen, and the liver. We know hematopoiesis, I can never say that, is the process of making blood, and those are talking about the pluripotent stem cells and erythropoietin and how those are created. We also deal with a lot with blood volume, with how many red blood cells are being produced and what's the liquid component, what's the plasma volume for that. We know that with red blood cells that there's a sequence for processing those, but we really need to focus in on what is the laboratory analysis of the red blood cells. So as far as what we're looking at, generally speaking, in a draw of blood that was put through a centrifuge that would spin it round and round and round and separate out the whole components from the liquid component, we would see that about 54% of the blood is made up of plasma, and that the red blood cells make about 45%. We refer to that as the hematocrit. We also measure the amount of oxygen capacity or carrying capacity that the hemoglobin has. And that's going to give us an idea as well between the hematocrit and the hemoglobin. Gives us a good idea of how well the body's producing red blood cells and if they're working effectively. We can see that this gets broken down into a lot of different components, right? So those formed elements that we talked about, there's anywhere between 250 to 400,000 platelets. There's anywhere between 5 to 9,000 white blood cells, and anywhere between 4.2 to 6.2 million red blood cells. That's a lot of formed elements when we start to look at those in numbers per cubic millimeter. Now, on the other end, we've got the liquid side, right? The liquid is primarily made up of water, but there are some things that allow for fluid shifting and things of that nature, and that's where about that 7% of what that 55% plasma is proteins, 91% water, and about 2% for other solutions or other solute. You can see that continues to break down into a number of different things. The big one we look at is white blood cells, right? White blood cells are things like neutrophils, lymphocytes, monocyte, eosinophils, and basophils. Those are the most common ones that we see, and you can see that the majority of those are going to be neutrophils and lymphocytes. We also know that as far as what proteins we have albumins, globulins, and fibrogen as well. And those are going to help with some of our clotting factors, and then some of our ability to have a natural immune system response, like we talked about in our anaphylactic and allergic reaction lesson. So the idea behind this is we typically see hematocrit about 45, we see our hemoglobin about 15, and our red blood cells about 5. And that's kind of the idea when we think of percent by volume, that's kind of what we're looking for here. Plasma, primarily water, 90 to 92% by volume. The proteins, we talked about albumin, those are the larger molecules at 6 to 7% by volume. And then the remainder, the other portion of it, is anywhere between 2 to 3% by volume. Those make up things like fats and carbohydrates, electrolytes, gases like oxygen and carbon dioxide, and then other chemical mediators. One of the things that's important to point out is the oxyhemoglobin dissociation curve. And this really does affect our hemoglobin on our red blood cells. How effectively are those carrying oxygen for us? And when we deal with those, we know that has a component of the Bohr effect, and that we see the hemoglobin dissociation curve. As it shifts to the right, we see a decrease in pH, an increase in CO2, an increase in temperature, and if we were to have a shift to the left, you're going to see an increase in pH, a decrease in CO2, a decrease in temperature, kind of the opposite components. And the further we get away from where normal homeostasis exists, the harder it is for the red blood cells to hold on to those oxygen molecules by that hemoglobin as it transports throughout the body. Now, we know this is primarily done by the Bohr effect. You'll have a chance to watch more and more in-depth video on that as we go through our lesson. But again, we know we've talked about this. Are we trying to see if we're having a left shift or is it a right shift? Lower blood pH, obviously they're more acidic. We know the hemoglobin is going to want to let go of that oxygen, and we call that a right shift. Right is not always good because we're losing the ability for the body to hold on to oxygen. So think about your severely acidotic, in severe respiratory distress from a patient with COPD. More and more, they're going to lose their ability to hold on to what oxygen as they become more acidic. So we want to try to keep them back into the normal physiological range, right, where we see homeostasis and acid-base balance occur in that 7.35 or 7.45. And so if we keep them in that range, we're going to be pretty well off. If the blood were to become more alkalytic, right, or have a higher blood pH, well, we know the hemoglobin is going to hold on to that CO2, and then we refer to that as a left shift. Now, a left shift's not as bad, but if it's holding on to it, it's not going to release it. It's not going to let it go to the tissue as effectively as it needs to either. So we want to try to make sure we maintain that. It's better to have your patient a little bit more on the alkalytic side than it is to have it on the acidotic side. Just something to kind of think about. And then again, if we're thinking left or right, left is our alkalytic, right is our acidotic, right? It makes it harder for oxygen to hit its target if we start to go left or if we start to go right. Primarily, if we're really dealing with the big issue, we're going to be seeing that right switch. White blood cells for leukocytes, these provide protection from foreign invasion. They're widely distributed throughout the bloodstream. They do go through a process of what's called margination, which is the cells are attached to the vessel wall. They demarginalize when the cells are released from the wall in a response to some type of stressor or an event that would need white blood cells to be released. For example, a pathogen or bacteria floating through the system, they would recognize that chemical reaction and then release to attack. The last portion here is diapsides, which I'm not sure if I'm saying that correctly, but it marginates the blood cells that are adhered to the vessel wall and leave the blood vessel itself, right? So they follow the chemical messenger to stay on it, to keep attacking it. The chemostaxis or chemical signals that's released, that's going to be what's there, allows for the body to recognize it and then begin to attack that invader. Phagocytosis is where basically you have a white blood cell, right, phagocyte, that actually goes in and it's going to engulf and destroy whatever that invader is. And again, like we talked before, your white cell count between 5,000 to 9,000 per microliter of blood. That's a good amount. White blood cells that reproduction process for that is leukopiosis, something along those lines. There's 3 primary categories: granulocytes, lymphocytes, and monocytes. It's important to know that white blood cells, they all start out as granulocytes and they begin to develop into what they need to from there. So you may have things like neutrophils or esophagils or basophils or monocytes. Those are different components that you're looking at. White blood cells, again, the granulocytes, the neutrophils, the basophils, and the esophagils. This is one of the ways that they look at it. They do testing by actually staining. So you'll see that if they go to stain them, what color do they turn? If they're both pink or blue, you're looking at neutrophils. Neither of them will react to the color changing dye. Basophils, they'll actually stain blue. And then the esophagils, with an acid stain, they turn red. And so the coloring allows for us to determine what's there. White blood cells, we know that lymphocytes, they're involved in the immune system response, and they're produced by both B cells and the T cells. Homeostasis is extremely important when we talk about hematology. Really, we're talking about the body to maintain what is considered to be normal. Controlling blood loss is important. We know we have vasospasms, vascular spasms to stop the loss of blood. We have platelets that will form a plug to stop blood from leaking out of the vessel. And then we get a nice weaving of fibrin that allows us to actually stabilize what blood clots we have. The term of homeostasis is used to describe bleeding after a cath procedure, or maybe you're doing some type of transport. The goal of that is we've stopped the bleed, we want to maintain that, and then maintain homeostasis as we move forward. Homeostasis really has to do with blood vessels breaking open. We know we get that turbulent blood flow and that reaction that begins to happen that identifies that there's a clot. Platelets begin to aggregate. We know we get the formation of fibrin, which helps stabilize the clot and weave that clot together. This whole thing we've talked about before with the damage to a vessel initiates a coagulation cascade. There are both intrinsic and extrinsic pathways, either activated by turbulent blood flow or activated by trauma. Let's go ahead and talk about general assessment and management of our hematological patients. In general, patients with a disorder of the hematology-like system or hematopoietic system may present with a variety of complaints and physical findings, right? So patients with infections, we know that there may be some white blood cell abnormalities. They could be immunocompromised or more prone to an infection. This could even be a transfusion reaction where a patient's receiving blood, right? And they may present with febrile-like symptoms. Subsequently, these patients may develop hemodynamic instability as this infection progresses into the point where it leads to sepsis, which we talked quite a bit about in our geriatric lesson. Or we may see the transfusion reaction lead to a more hemolytic reaction, right? Things like renal failure or disseminated intravascular coagulation, DIC. Acute hemodynamic compromise can also be found in patients with anemia, right? So they get anemia secondary to some type of acute blood loss. Maybe they got a coagulation deficit or an autoimmune disease. These disease processes may not easily These disease processes may not be easily differentiated in the field and often are going to require significant laboratory testing to confirm whatever that diagnosis is, right? So in most cases, however, if you obtain a careful history, you'll get enough information to create a strong working diagnosis. Most of the hematopoietic disorders are some type of chronic condition that present with an acute exacerbation when the patient is exposed to additional stress such as an infection or trauma. Treatment of these patients with these disorders in most cases is really just supportive. Some patients, however, may find that they need to have interventions like IV fluids to support end organ perfusion or even to prevent or hold off shock as long as we can. In addition, they should receive oxygen therapy to prevent hypoxia from poor perfusion and diminish oxygen carrying capacity of the blood. It's also important to recognize that the need for rapid transport in patients with hemodynamic instability who may require transfusion or other definitive care measures. So if you need to go, don't be afraid to go ahead and pick off with these guys because they oftentimes can be critical and we don't really carry the tools or treatments they need. Always contact medical control for any questions or direction you have or any problems that you lead up to. We know that with seeing size up, the big thing is going to be the assessment of our patient with a possible hematopoietic abnormality begins the same as it would for any other patient. Perform your scene size up, take standard precautions, and then during your approach, form a general impression of your patient. Is this a medical problem or is this a traumatic problem, and how much distress is my patient in? Your primary assessment really is going to focus on life threats, right? Determining responsiveness, assessing the airway, breathing, circulation, and we know that alterations in the hemopoietic system may present as life-threatening bleeds or overwhelming infections with septic shock. So do not spend time obtaining a complete set of vital signs during the primary assessment. Focus on just the ABCs to quickly determine your priority and transport decisions for this patient. Remember, critical or unstable patients should be considered candidates for expedited transportation, transport. Your secondary assessment, use your general impression to guide you as you go through that. For unresponsive or responsive medical patient or even a trauma patient with significant or non-significant mechanism of injury. Let that your primary view from the door, right? General impression, paint the picture or paint the pathway that you should travel for that patient. Remember, with trauma patients and unresponsive medical patients, they're often times a life-threatening problem that you're going to have to know as part of your primary assessment or maybe find in your primary assessment. Your history for a responsive medical patient, obtain sample and perform your physical exam. Get a set of vital signs and place on things like the pulse oximeter or capnography. Keep in mind that an anemic patient will oftentimes have an increased heart rate and an increased respiratory rate as the body tries to compensate for the lack of oxygen reaching the tissue. Ask for the chief complaint. Why did the patient call for ambulance today? What did they need? Pay attention to their generalized complaints such as fatigue or being lethargic or generalized malaise. Maybe they're apprehensive or even slightly confused. These types of issues may indicate inadequate oxygen delivery to the tissue. Have there been any unusual skin changes and other coloring or bruising issues? Does the patient complain of any type of itching? Inquire about lymph node enlargements or issues with swollen glands, sore throat, or pain on swallowing. All these could indicate an infection for our hematologic patient. We know that as there's going to be additional changes in the body's ability to deliver oxygen to the tissue, it's going to affect the cardiovascular and the respiratory system. So we want to make sure that we recognize that. Patients with hematological problems may suffer from a syncope as well. We want to know, did the patient have a syncopal episode or are they just weak? Syncope can be due to a number of different factors, but we know one of the common reasons is marked anemia. We also want to know, have they had any bleeding? Bleeding in their vomit or bleeding in diarrhea? Don't overlook the complaints of nausea or anorexia or vomiting of coffee ground material or even having black tarry or cranberry. It's another way I've heard of it recently. Cranberry sticky, very odorous type stool. Many patients will notice bleeding of the gums when they brush their teeth if they have a hematological disorder as well. Kind of a weird question to ask, but it may paint the picture for you a little bit better. This can, on occasion, be hard to control if they have excessive bleedings from the mouth or from the gums. Non-traumatic or atraumatic bleeding is almost always a point of some other underlying hematological abnormality. So it makes you ask about those changes. For the female patient, remember this may include things like change in their normal process of menses as well. We want to get our sample history. We know when we ask about the sample history, we want to know any surgeries and medications that they've been on, anything that would be prescribed potentially for a hematological disorder, and what might they be taking, right? So this includes things like pain relievers, antibiotics, anticoagulants, hormones, and other medications for other diseases like heart disease, arthritis, or seizures. We want to pay attention to things like alcohol consumption, smoking, IV drug use, any type of long-term exposures that they may have had. They may be more prevalent for determining some type of bloodborne infection then, like HIV, hepatitis B, or hepatitis C. Obviously, make note of the liver and or any bone marrow disease or any cancers that you may have determined as well. Now, your physical exam, when performing the physical exam, evaluate each system methodically as you would any other patient. If the history suggests a hemopoietic problem, look for a potential pathology during the physical exam that may confirm your working diagnosis and give you a clue to developing complications. Now, lastly is the nervous system. When we think about the nervous system as part of our physical exam, we always want to evaluate it first, especially if they're having a hematological problem. First, evaluate the patient's level of consciousness using the AVPU scale. Watch for things like weak and dizzy, and try to clarify any abnormal or ambiguous information from your patient as much as you can. Ask them, have they been fatigued? Are they weak all over? Do they have a specific focal point for weakness? Are they dizzy or suffering from any type of true vertigo? All of those can be associated with signs of anemia as well. We want to know as far as how do they look in regards to their skin, right? So when we think about their skin, what does a patient's skin color look like? Do we notice jaundice? That's going to be a sign of yellow skin, which may indicate liver disease or hemolysis of the red blood cells, whereas fluoride or the reddish appearance is often associated with things like polycythemia. Patients with anemia typically exhibit pale skin, things of that nature that you would typically look at within your patients. Pay close attention to the colors of their eyes. That can oftentimes give you an idea of what you're looking at with your patient. Most of your general treatment that you're going to look at for these guys is going to focus in primarily on paying close attention to the airway and breathing, airway and ventilation status of the patient who's experiencing any type of alteration from a hemapoietic emergency. Place the patient in high concentrated supplemental oxygen, especially if the patient is hypoxic, and monitor breathing for difficulty or fatigue, and be ready to assist with ventilations with your bag valve mask. Assess your circulatory system. Consider the fluid volume replacement, but remember that crystalloid solutions don't carry oxygen, so Too much fluid can actually dilute the blood and reduce its capacity to carry oxygen, and we want to stay away from that. We also want to be alert for any type of arrhythmias and treat them accordingly as we find them. Based on your assessment and evaluation, create the optimum environment that for the blood to perform its tasks of oxygen delivery and waste product removal, right? Make sure oxygen can get to the cells and tissue, and CO2 and waste can be picked up and expelled out through the lung. We want to try to create an environment that may include things like giving the patient aspirin to inhibit platelet aggregation, or ventilating the patient to compensate for any type of acidosis and allow for oxygen to unload from the hemoglobin at the tissue. And again, transport these patients primarily to an appropriate facility that's going to allow for you to be able to comfortably assess and provide the comfort measures that you may need, things like analgesia, or really more commonly just psychological support for your patient and their family. So guys, that's our introduction to hematological emergencies. Obviously, there's a lot of things under the general assessment and management component that we need to be aware of. The biggest ones that we're going to be dealing with are going to be ensuring that our patient has an adequate oxygenation and adequate circulation. Those are probably the biggest two that I can send you away with. Pay close attention to the questioning you have, pay close attention to the medical history, pay attention to the way that the patient presents and their physical signs. Those are going to be things that will allow for you to clue into a more specific problem as we go through with our lesson and you see these interactions and encounters in the field. We'll pick up next with our specific management of hematopoietic disorders.